All right, good afternoon, everyone. Not good morning. I'm sorry about that before. They've gone by so quickly. This is Olivia Hendy from the New England QIN-QIO, and thanks for joining us for today's webinar, Interact Session 3, Medication Reconciliation Tool, with Sheila, Eckenrode, Florence Johnson, and guest speaker Andrea Leschak, who we will introduce in a few minutes. Before we get started, I'm going to quickly review a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of this webinar. And the phone lines will be on mute for the duration of the presentation. We'll take questions after Andrea's presentation and then at the end, and I'll provide you instructions on how to unmute your line. Or you can pose a question during the presentation or during that time in the chat box. Make sure that you send questions to all participants so that we can keep up with the incoming questions. I'm now going to pass it over to Sheila to get us going. Sheila?
Thank you, Olivia. Hopefully everyone can hear me. And welcome, Interact Pioneers. We're glad that you're here with us today. I just want to go briefly over the objectives of today's session. And it is, of course, to welcome you to nursing homes in Connecticut. And Olivia, I might have to ask you to move the slides. We're having a little trouble here. Can you give us slide number 2, Olivia? Oh, thank you. Thanks, Olivia. All right, making sure it's good. Okay, the first thing we want to do is welcome all our Interact participants and our Interact partners. We're glad that you're here. Today we're going to talk about medication reconciliation, the process of medication reconciliation, and we'll touch on a few of the tools that are out there for use in this process. Interact has an excellent tool, and there are other tools that our speaker will briefly touch on, but the most important thing is to understand the process. The tools really don't drive the process, the intent of medication reconciliation, and the goal should drive the process, and the tools should supplement that and help you along. We're going to spend a little bit of time, if we can, talking about developing a plan of implementation for medication reconciliation using one of the tools. If that's something you need to do in your home, if you don't have that process embedded already. And then we're going to talk a little bit about the last 2 months' homework. I hope we have a presenter here today with a wonderful fund of knowledge, and we want to give her as much time as she requires to get through the presentation. So if we get a little tight at the other end, we'll compress that, and we'll let everyone busily be on their homework. And just to touch base with you about homework from previous sessions, I have a couple of polling questions. So the first polling question, if we can get that up, we're asking if you have a team at your facility that works on Interact implementation. So, Olivia, I'm sending that polling question up. Yes, I see it. If you could just answer that, we would be so grateful, because that helps us know if we're having the desired effect, if we're spreading this Interact process across the state. So, just tell us yes or no. It's anonymous. Do you have a team working on Interact implementation? And after you answer yes or no, be sure to hit that submit button in the bottom right-hand corner of your screen, because that's what will make the results come up. Thank you.
All right, looks like the poll has ended.
Okay, thank you. Thanks, Olivia. We can't see it on our end yet, but that's okay. It's looking good. We're getting somewhere. Okay, I've got a second polling question. This is going to keep you engaged and keep you in front of your computer and not wandering off to do other things. Is the leadership at your facility committed to Interact implementation? Do you feel that you have the support of senior management? Again, this is yes or no. And if you could just hit that submit button in the lower right-hand corner, give you about 35 seconds, I think, to answer that. Thank you. Okay.
We'll just give it a second to come up, Sheila.
Thank you, Olivia, because it's good for the participants to get the answers to these questions as well. Thank you very much. That's looking great. And one more question, and then the test is over. The last one is, are you entering data into that 30-day hospitalization tracking tool that we talked so much about in our last session? Are you using the Advancing Excellence tool or the Interact tool? And if you're using a corporate tool, a tool that maybe is designed by your parent corporation, you can answer this yes as well. And again, if you would just be so good as to hit submit in the lower right-hand corner, and I thank you very much. This is our way of sort of testing the waters and seeing if Interact is, the seeds we're spreading are taking hold and are going to blossom soon. So thank you for that. Just a couple more seconds. That's great. That's looking great. Thank you so much. So I'm going to turn this over to Florence, who's going to introduce our guest speaker, and she's going to talk for a while about medication reconciliation.
Thank you, Sheila. It's with great pleasure that I introduce Dr. Andrea Leschak. She's a Pharm.D. She received her doctorate of pharmacy degree from Mercer University in Georgia. She spent more than 20 years working for various pharmacy leaders that include both Walgreens and Target, in addition to living abroad as a contractor for the United States Army. Additionally, she worked at Omnicare of Connecticut as a consultant for more than 6 years, focusing on geriatric care prior to joining the faculty at the University of St. Joseph's School of Pharmacy as an assistant professor. Dr. Leschak's clinical interests include geriatrics, wellness, and longevity, and the development of pharmacist-based clinical services inside the long-term care center. Her practice site is at Doncaster Retirement Community in Bloomfield, Connecticut, where she works with both administrative and clinical staff to identify opportunities to improve resident care, enhance medication safety, and reduce hospital readmissions. So at this time, I'd like to give the floor to Dr. Leschak.
Good afternoon, everyone. Do I have the ball? I'm just curious real quick. Yes, I do. Fantastic. Thank you. So thank you for sharing your time with me today. A few comments before we get started. While the goals of MedRec are fairly straightforward, and those are to develop the most accurate list of medications at a point in time, to guide our therapy, and to ensure the correct medications are used throughout all transitions of care, the process of actually completing a comprehensive medication reconciliation can be time-consuming. For those of you that are new to MedRec, please recognize that the time allotted today is barely enough to skim the surface of this process. Acknowledging that, my personal goal for today is for everyone to gain a more thorough understanding of the ultimate purpose of reconciliation, and then to take that knowledge back to their care settings to determine how best to apply the principles to improve patient care. Of course, you know we have to have objectives. Oops, I went too far on that. The objectives for today's presentation: to define the medication reconciliation process, to be able to identify key healthcare team members who will take ownership, in essence, of the process, to list the components of the medication reconciliation process, and then to apply the MedRec process to your specific practice environment. So, I'm having difficulty over here with screen advancing for some reason. So, why are we here to talk about medication reconciliation? What is the need, or why is the need to implement MedRec in the long-term care setting gaining such momentum and a sense of urgency right now. So I'd like to present you with two simple scenarios that are somewhat representative of common long-term care patient admissions. The first one is a gentleman who's more than 80 years old. He comes into the care facility. The W-10 has a number of medications. In this case, it's more than 15 medications and various supplements included. The family provides an additional list of medications and supplements. And when the two documents were compared, there were approximately 10 medications that were not included, or they were not common to those documents. And so in reading the home ed list, we noticed that it contained a prescription eye drop to treat glaucoma. However, the hospital information never mentioned that the individual had glaucoma. There was no diagnosis listed for glaucoma, and nor was there any eye drop on any of the paperwork that came from the hospital with this gentleman. In another case, a 70-year-old plus individual was admitted into the care facility, and the nurse, it was a handwritten W-10, and there were multiple medications, and the nurse read the order to be amiodarone 400 milligrams twice a day, transcribed the orders over to the medication administration record and the physician's order sheet. The drug was ordered and was delivered, and about 3 weeks later, the consultant pharmacist comes in to do that monthly medication review that everybody's familiar with and notices that this dose for amiodarone is quite high, particularly at the time, the length of time the drug had been used. Goes back to the W-10, and the discharge information is basically trying to do a med-rec, and notices that the W-10 was originally used with a fax document, and the amiodarone was written on the second or third line, and the drug above was written X milligrams. The G from milligram above had crossed the number 1, making it appear to be a 400, but it was actually amiodarone 100 milligrams twice a day. So, obviously, a difference to what we expected the person to have. So, based on these two examples, I'm sure that you understand that our patients in long-term care often take a large number of medications and may also be on high-risk medications. Though not a part of my specific scenarios I just discussed, a 2014 CMS report on adverse effects identified that hypoglycemic, anticoagulants, and opioids as the 3 most common drug classes involved with ADEs. So understanding the scenarios and the challenges that we have in terms of transitions of care, let's talk briefly about the impact of adverse drug events and the error and the economic burden that this puts on our system. In 2013, and this is what the information on this particular slide comes from, in 2013, the Institute for Safe Medication Practices issued a bulletin that outlined a number of findings, and I have included this. 70% of all admissions to long-term care have at least one medication discrepancy. Now, that may not be an error, but it's a discrepancy between the various pieces of paperwork that the care facility receives. Up to 6% of discharge summaries and transfer forms contain discrepancies as well. And greater than 21% error rate occurred during the handoff between the hospital and the long-term care facility. The economic burden of medication error is so found that it's a little bit more difficult to accurately state, in part to the variability of how medication errors are reported, and in addition to what is actually considered an error. In 2014, the U.S. Department of Health and Human Services released a report stating that adverse drug events contributed to approximately $3.5 billion, and that was in 2006 dollars, to U.S. healthcare costs. And I've also, in terms for researching this presentation, I saw this number reported as high as $5 billion. So there's obviously a challenge in terms of what our, in terms of what we're faced when we admit somebody into the care setting, and then also the economic challenge that happens. So now that we have some background on the importance of med-rec, what is medication reconciliation? And that's what we have here. It is a patient-centric process used to develop a patient's most accurate medication list. It contains drug names, the dose, frequency, and administration route. It includes all medications, prescriptions, over-the-counter products, and supplements. This also means it includes topical, inhaled products, drops, and any other type of medication that's ingested. And it's very important that we remember that, the prescription that's used for eczema is just as important as the blood pressure pills. It helps us guide therapy to ensure your medications are omitted. And with respect to guiding therapy, pharmacist integration into the MedRec process is key for optimization of therapy for our patients. And then lastly, it ensures that the correct medications are provided at all transition points of care. Oops, sorry about that. So I like to view MedRec as a safety net that helps us prevent omission of critical drug information from the patient record. If we refer back to that gentleman with the glaucoma and the eye drop, a thorough medication reconciliation should have caught the fact that the patient was using an eye drop. The patient was aware that his eye drops were missing and that he wasn't receiving the product. When I went in to meet with him with my students, we asked him, do you have glaucoma? And he looked at us and said, yeah, I have glaucoma. I've had glaucoma for years. And I can't find my eye drop, so I don't know what's, I don't know what's going on. And so he was more than able to tell whomever who had talked to him that this is going on. So definitely, important to make sure that we ask these questions. And I am realizing, looking at the slide, at least on my side, that the slide is compressed for some reason, so I'm hoping that this didn't move throughout the presentation. Medication reconciliation is also valuable for providing insight into adverse effects. Artificial tears, I have those listed up here, can certainly be used to treat dry eyes. However, it may also be an indication that the person is experiencing an adverse effect. If the person is taking anticholinergic medications that are known to cause dry eyes and blurry vision, this may inadvertently increase the risk of fall. So again, evaluating the therapy, even on something as simple as an OTC, is important in our population. So, the medication reconciliation process. MedRec is generally broken down into 3 steps. Step 1 is the verification step, and this is where we collect that medication history. Step 2 is the clarification step. Are the drugs and doses appropriate? And I'm going to be referring to these steps over and over again as I move through this. Step 3 is the reconciliation process, where you document any changes to your orders. Now, I'd like to point out at this point on in the presentation, I'm going to be demonstrating the mechanism that we at my practice site use to manage medication reconciliation. At this time, there really isn't a one-size-fits-all MedRec process. I know that there's hopes that it will be developed, but at this time, there really isn't. If we were to Google MedRec on the internet or any search engine, you would find a number of different forms. Interact does have a medication reconciliation form, but this is what we have adopted to make that works in our particular setting, and it works with our resources. So the details may not apply specifically to your site. However, I do hope that you're able to take the opportunity to consider the information and then how to apply it to your care setting and devise your best approach to introducing the MedRec process. So as I've already said a number of times, step 1 is verification. And this is where you collect all that information about your patient's medications. So you're going to be drawing information off the WCAN. You're going to be looking at the discharge summary. You're going to be looking at the medication list for the person from the home meds. You're going to conduct a patient interview. You may need to speak to family members if there's cognitive challenges. You very likely will have to go as far as calling an outpatient pharmacy and possibly even the standard primary care provider. Now, if you were to talk to many people in long-term care and ask, do you do MedRec? Most people would say, yes, we do MedRec. And then if you ask them to define what MedRec was, they would usually reply, well, we take the information off the W-10 and the discharge summary, and we transfer it to the physician's order sheet or the MAR, and, that's our medication reconciliation process. So, at least up until recently, that's what many people in long-term care thought was medication reconciliation. But all these other bullets I mentioned here are crucial to the full MedRec process. You have to go and speak to the patient and find out, what the patient was really doing with the medication. It's not enough to just look at a discharge summary and see Actipril 10 milligrams once a day for blood pressure. Because unless you speak to that resident or the patient, you don't know how the person really took the drug. What they were really doing was cutting the tablet. So they were only taking 5 milligrams a day. Or, better still, in their mind, is they're taking the tablet every other day because they wanted to extend the life of the prescription to be able to save money. So your paperwork may say one thing, but the patient could be doing something completely different, and you don't know this unless you go and talk to them, or the family members. And sometimes it gets really complicated, and even the patient's confused because, and I'm going to show you a situation of how this can happen, and you may have to call the outpatient pharmacy or pharmacies, if they use more than one, and ask the person, ask the pharmacist, what did they pick up recently? What drugs are actually being purchased? So that you have the full information. So, step 2. Clarification. After you collect the information from all these different sites, ask yourself, are the diagnoses appropriate for every medication? And again, this is not at admission, seeing a list of drugs and seeing the use of Actipril and assuming that the person has high blood pressure. It is in talking to that resident, I see that you're using this medication, Actipril, and why do you use that? And if the person does your high blood pressure, well, there you go. You have your diagnosis. And if you can't find diagnosis, it's talking to the provider to determine what the accurate diagnosis should be. Are there those discrepancies on the collected information? We get a number of documents that will have multiple doses of drugs. And my assumption has always been that it depends on when the discharging institution is printing paperwork that sometimes seems to be skewed a little bit. But, if there's dosing discrepancies, these are things that have to be followed up on. Is the appropriate monitoring documented and ordered? And in long-term care, this is particularly valuable to do it at MedRec. When you sit there and consider, what about your patient, your resident that's being admitted on an antipsychotic? Well, everyone in long-term care knows that if you've got an antipsychotic, most likely you've got a number of things that have to happen when that drug is put in play. So, is there a target behavior flow sheet being monitored? Is the AIMS test scheduled? Are we going to be monitoring orthostatic blood pressures? This is a time to find out and catch those things in the process of doing the MedRec. Are there duplicate drug products? It could be reasonable to have 2 different albuterols in play, but it may be an error. So following up on that, do we have a complete allergy list documented? And this somewhat ties into the confusion regarding therapy of where sometimes you have a W-10 that will say a patient has an allergy to a product, yet a family member or even the patient's like, oh, yeah, I take that all the time. Where's the confusion? So actually talking to the resident and patient, finding out how, here I have documented that you have an allergy. Sometimes we'll see one for simvastatin, an allergy to simvastatin. Going and talking to the patient. What happens when you take simvastatin? Did you have troubles breathing and have an anaphylactic shock episode, or did you have muscle aches and flu-like symptoms? Because it will matter what drugs that are used downstream. The third step is the reconciliation process. And this is basically when you take all the information that you have, and then all of that clinical thought processes, you put it together and you speak with the provider, whether it be the PA, the APRN, or the physician. And the physician or whomever is the final person that signs off on this MedRec goes through and makes the decision of what products and what drug therapy is going to be continued as we move forward. And that everything is consistent and documented appropriately across all forms of communication. So, as I mentioned earlier, I'm going to deviate from the interactive because this is the process that we used in our building. And so I'm just going to walk you through how we do a MedRec. This is what our form looks like. It's pretty streamlined. It's all single page. It's a PDF writable file, so it makes it nice. At the top, we have the patient information, as you can see. We go into an area that we can very quickly type in the drug names, and as you'll notice, that it's not only the medication name, but the dose, the route, and the frequency. I'll get to that part at the end that says physician continued medication. In this section here, we like to track what the origination or the origin of the order is. So we have the W-10, the PCP, and the home, or our home med list. I can tell you right now that this form is not correct right there, and I'm going to explain to you that even though we thought we came up with this very streamlined process, how we're still learning how to adopt MedRec in our facility. And then we have areas for the primary contact information, a physician, and then this over at the end, this is what happens at MedRec. So this is that step 3, where the physician sits down with the nurse or whoever has this information, has that discussion of what products are going to be continued in the care setting. So atorvastatin 10 milligrams daily, and it is continued. So that's how it is documented. So what I have here are 2 examples of paperwork that was brought into our facility. And what I like about this is that it touches on many points that I brought up already about some of the, so you have the pre-hospital medication and your discharge, but it also shows how patients can get confused. So here on the left side is our pre-hospital medication. And on the right is the discharge home med list, or the list that the person would have been coming into with the care facility. What I hope you notice here is that there are 3 different orders for potassium chloride included on these 2 documents. So on the pre-hospital medication list, there's a Chlorocon 20 milliequivalent tablet once a day. There's a potassium chloride 10 milliequivalent once a day. And then on discharge, K-Tab 10 once a day. So I just listed 3 different ways to say the same drug. Now, I'd be willing to bet if you talk to a patient or a resident, a number of them would be confused by all these different names, yet it's all on their individual paperwork, and they may have a copy of this sitting around. Also, I'd like to point out, as I mentioned earlier, on this pre-hospital medication list, did anybody ever confirm with this particular resident if he or she was really taking 30 milliequivalents of this drug? Because that's a big difference between what was coming in, what the individual came in with, and what they were being discharged on. Not to say it's not right, but it is a big difference. And this need to reduce the potassium dose could be vital information moving forward with this particular patient's care. And so I like this document shows us how easy it is to, 1, create confusion, and then 2, it may also create confusion in terms of what you write down on your admission paperwork. So just remember to collect all the information. This is step 1. You collect the information from all your sources, the W-10, the discharge summary, the home med list. You have that resident interview. You ask this person, how are you taking your potassium? When you're taking those tablets, you just clarify everything right here and now. So then we get to step 2, the clarification phase. And this is when you go through the paperwork and you try to make sense of all that information, everything that you have. So that didn't show up in the right place. That should actually be highlighting in the center where the W-10, PCP, and home is. The reason that should be there is to show you how I had mentioned earlier that this particular form is not going to, this is not 100% accurate. Atorvastatin on this list is documented as coming from the W-10, the PCP, and the home med. I can tell you here that for this particular form, the PCP was not contacted, so there should not be an X underneath the PCP. There should be basically a W-10 and a home where they have X. And so here you can see, and I have a feeling this entire slide is going to be skewed, so I do apologize for that technical issue. If you can imagine, this red box will be up 3 lines with the Chlorocon 20 milliequivalents a day. Again, 3 X's marking where the W-10, the PCP, and the home is. I've already pointed out that that would not be accurate, that the QIO-QIO 20 was discontinued in the hospital. So this should actually not say, and that's going to cover it, so again, I apologize for this. The QIO-QIO 10 is what was continued at discharge. And so basically there should have been an X over the QIO-QIO 20, and that should say no, and all of these are going to be in the wrong spot. And so basically KTAB 10 should have been at the bottom. So I do apologize for this, the quality of this particular slide. And thankfully we can move forward from this. So reconciliation, how can we make peace with all of this? Then we would reconcile this particular product, or this particular document, and we would determine which medications would continue on the residence chart. So going back to the 3 steps of medication reconciliation. Step 1 is the verification, where we collect all of our information. And again, it does include a residence interview or a family interview if the resident is cognitively impaired, and then possibly even calling the outpatient pharmacy. Step 2 would be to review the diagnoses and to look for allergies or any dose discrepancies, and to make sure that duplicate therapy is resolved if you find any. And then step 3, after discussing any of these new findings or any of the challenges that you have, you would then go on and reconcile this with the provider to make sure that what is really required for the resident is appropriate. For the medication reconciliation in your setting, how do you adapt this process to your personal care environment? Who is going to own it? Inpatient settings have been performing medication reconciliation for years. In most settings, pharmacists are the ones that own MedRec. So if you go to a hospital, many hospitals, pharmacists are the ones who do the medication reconciliation. Nurses and pharmacy technicians and other staff members may be involved in the process of collecting information or meeting with the patient, or it's the pharmacist that really own it and drive it. And as I highlighted in step 2, the clarification, the optimization of therapy, that's really where pharmacist expertise is invaluable to this process. That said, we know that the long-term care model is quite different than in hospitals. In long-term care, we have a consultant pharmacist that visits on a monthly basis. An individual that visits on a monthly basis would be highly challenged to be able to perform a MedRec because of the time constraints that I've shown with the complexity of these forms. In long-term care, the responsibility for much of the MedRec process seems to be falling on nurses. However, we also know that the nurses' work burden is already quite robust. I can remember when I was consulting and seeing the 3-hour med pass. There's a number of patient concerns, the discharges, the family responsibilities, and all the other nursing responsibilities that go into play with doing the job of nursing. And so MedRec may feel like it is adding another layer of complexity to the nurse workload. So at my site, and that's why I showed you what we do, at my site, other than when I'm teaching or on vacation like I happen to be today, I'm in the building 3 to 4 days a week. We've taken steps to streamline our process so that the nurses complete the MedRec in terms of the documentation, they meet with the patient, and then they also, of course, are meeting with the physician, reporting back any of the discrepancies that they might find. Then we, my students and I, we go back and we audit the MedRec forms, and then we conduct follow-up interviews, if we need to. We reconcile some of the more complex discrepancies if we found something that seems to also be out there. And then we review that information for clinical interventions to optimize the therapy. And then I go and meet with the medical team and we make those recommendations at another level. I understand that this will not work for everyone. Generally speaking, you'll need to review your resources and determine how to make that process fit into your model of care. I do think that the MedRec process highlights a larger challenge in long-term care, and that's how we're going to integrate pharmacist onto the care team, that I recognize that it's a completely different topic, but one that becomes relevant when you start to look at implementation of a comprehensive medication reconciliation process. But regardless of that, certainly now, whatever your resources are, the beginnings of medication reconciliation can certainly be adopted and put into the majority, if not all, I would believe all, long-term care settings that we have in play already. So I'd be happy to answer any questions, and again, I do apologize for the slides. That was not intentional. And any questions or comments?
Thanks, Andrea. And at this time, you can take a few questions for Andrea. To ask a question, please unmute your line by pressing #6, or you can pose a question in the chat box below, which we are monitoring. Please make sure that when you do pose a question in the chat box, you are posing it to all participants.
Okay. I'm not seeing any questions on my side. How about you?
Andrea, it's Florence. Can you hear me?
Yes, ma'am.
So, typically, how long should it take someone to do a med reconciliation?
That is an excellent question. How long can it take? If some of it, well, let me back up. A large amount of that, it will depend on the complexity of the medication profile. If you have a resident that comes in and they're taking five products, and one of them is vitamin D and maybe some calcium and a laxative, and the patient is cognitively competent and knows their medications, filling out that paperwork and having that interview, depending on what else the individual who's doing this has going on, it may be 30 minutes to do that extra step of doing the med rec, and that's not really that much when you think of everything that's going on with what I listed. In the case with the person with 25 medications, I think that's really an extreme. Both examples are extreme. The 25 is an extreme and the 5 is an extreme. We know most people have somewhere between 10 to 12. You could easily be looking at an hour, if not more, to do that, to do the whole process. And some of it will depend on the tool that you're using. If it's an EMR and how easy it is to transfer that medication over to a form or whatever type of document or process the person's using. But to have a patient interview, a patient interview might sometimes take up to 30 minutes just for the interview if you've got a number of medications. And so, it's a very varied time difference, and it's driven really by the complexity and, how easy it is to communicate with your patients. So I'd say 30 minutes in a best case scenario, if you have not a lot of products, that it could easily get up into the hour and a half to 2 hours to follow through everything. And you may not be doing that all at once. Don't get me wrong. We are using it. We have multiple nurses that work this process through. So they start it on the evening shift, or I guess that's the night shift, once the person's come in. And then the day shift nurses pick it up in the morning and they follow through. And then if the providers do have their final meeting, sometimes that happens in the later afternoon, evening. So it's not like somebody sits down and does an hour or 2 hours of work at once. It does get broken up through, in our particular situation, through multiple individuals.
Great, thank you for that.
Mm-hmm.
So any more questions from the audience?
Hi, Andrea?
Yes, sir.
Hi, it's Billy Boyce. How are you?
I'm doing good. How are you doing? I remember you.
Good. I'm so glad to hear you speak. Very well done.
Thank you.
Yeah, nice to hear you. I was just wondering, between the hospital base and the long-term care, you and I have worked together and we know how it kind of functions at the long-term care setting, but a lot of times when the patients go into the hospital, there's such a variation between the medications that they're taking at home, like you were talking about, and then when they're coming from the hospital. are we trying to push at like every angle? Like I think for long-term care, it's great. We should really involve the family members probably more with the interviewing process for the medications, or like you said, if they're taking half tabs and stuff. But would this like be a great push for like the hospitals too?
Well, the hospital, in essence, in a perfect world, medication reconciliation is supposed to happen at every transition of care. So, in essence, in an inpatient setting, if the person went from one floor to another unit, that could trigger a NEDREC. And so, you would, and like I said, that's the perfect world. And so, one would have hoped that the hospital would have already, worked through some of these difficulties, and that we would be giving the correct information. But unfortunately, like I said, we've already seen times where the medications, for whatever reason, don't print out properly at discharge on the forms. I've seen people leave the long-term care setting and then go back into the hospital, and for some reason, it's the worst-case scenario that I was talking to a colleague the other day. The person was on hospice or palliative care in long-term care, went back into the hospital, and somehow all those medications were resumed back in the hospital, and then came back, and it was only because the nurses knew the person that they knew that they shouldn't be getting all these products. And so this really does need to happen everywhere, and so for us, on our side, we just have to be very, very aware of what's going on and communicate at that transition of care what products leave with the patient, and then be diligent when the person comes back.
Right. Yeah, maybe if we had all the stops, then we could prevent, errors.
Oh, yeah, definitely.
Okay, thank you so much, Andrea. I appreciate it.
You take care.
You take care now, too.
Okay.
All right. Any more questions? Okay. Unmute your line. Okay. So we will move on. Andrea, we thank you so much for taking time out of your vacation to present to us today. This was a wealth of information, and we really appreciate your time.
It was my pleasure. I hope everybody has a fantastic day.
All right. Thank you. Thank you, Andrea. It's an important topic. Okay, so it's Sheila on the line again, and I just want to take a few seconds. Andrea, could you pass the ball back to Olivia, please?
In the office. Okay. I think I got it. All right.
I think everyone on the phone is saying, what is this ball? Okay. It's
Sorry about that.
Okay, I just don't want to take up too much more of your time. That was a lot of information to absorb. But I do want to touch base with our participants to talk a little bit about the homework that's been assigned for the last 2 months, and hear from anyone that wants to know about a successful implementation or ask for help from the group on a particular issue. So if you remember, the very first time we met, the homework assignment was to develop a team, and for the team to go to the Interact website and look at the tools and look at what was there and just figure out how to find it, to present the project leadership, to ask for leadership support of the Interact implementation, and to begin to talk about it to staff. Does anyone want to share how that's going for them, or does anyone want to ask for help from the group if there's a particular place that you feel hung up? Again, you need to press *6 to unmute. *6 to unmute the phone, or you can put a comment in chat. Okay, we saw from the polls that most of our participants have been able to develop a team or to fold this work of Interact into an existing team, so that's great. Anything else about leadership that anyone wants to share? or ask for advice and support? Are you finding that your medical directors, your administrators, and your corporate parents are, for the most part, supportive of Interact implementation? Just press pound 6 to unmute your phone or type something in chat if you'd like to share. Anyone encountering any barriers to finding the Interact website or getting the tools off the website? Everyone's quiet because it's so nice out. They're looking out their window. And they're thinking of the 20 medications that their recent addition came in with and how they're going to reconcile them. I won't push too hard if you're not up for sharing. If you know where we are and you know how to reach out to us if you need help with any particular piece of this project. The second session, we had some homework too. We asked that everyone register for Advanced Excellence, which I'm pretty sure not everyone's done, but again, I'd encourage you to do that. I'd encourage you to visit that website. There's a lot of tools. There's a lot of help to be found there. And it's free, which is just about what our budgets are going to allow with our state cuts. And it looks like in the polling questions that several people have been tracking readmissions in some form, either on a Advanced Excellence, using the Interact tool or paper corporate tool. Anyone want to share how that's going? Has everyone been able to find one person to assign this task to? One or two people? Is it a struggle to find someone to monitor this? Again, you want to hit pound 6 to unmute or type in chat. All right. A quiet group, as Florence said. Maybe we just absorbed enough information for one day, and that's okay. So no comments or problems with homework from the second session, so guess what homework is going to be from this session? I'm sure you can guess. The team leader of your Interact team will download the medication reconciliation tool from the Interact website and hand it out to the team to review. If you've got a medication reconciliation process and tool that you feel is working well for you, don't change it. If this is going to be something new to you, I encourage you to use the Interact tool because it's pretty easy to use. This is a big thing to implement, and you know, I think anyone who's walked this path appreciates the amount of time and commitment that this takes, but it's so important, and it's such a service to our patients in terms of safety and in terms of moving care forward. So please do that with your team in the next month. Look at that medication reconciliation tool, talk to your nursing staff about how they could see this process being implemented. Share stories about medication errors across transitions of care, because I think they're powerful, and I think almost everyone has one. Either one of their own, one from a patient, one from a parent. We've all had this experience. So, Sheila asked you to download the tool, and if you have something that your parent company is using that's working well, to work with that. Mrs. Florence, I would like to ask out that if you do have a tool that's working very well for you, if you wouldn't mind sharing it with me. I'd like to see what people are out there using, and maybe we can all help each other by finding best practice.
Thanks, Lori.
All right.
So one more question.
I'm sorry?
I was just going to thank you guys.
Okay. One last call for questions, comments, declarations, curses, condemnations. All right. Thank you for your time, and we'll see you next month. And remember, we're always here for you. So call, email anytime.
Okay,
Thank you for your participation.
Thank you all for a great discussion. I just have a few last-minute announcements before we end the call today. When you close out of the webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill out the evaluation right now, or you're currently sharing the computer with someone else, you'll receive an email tomorrow morning with the link to the evaluation, as well as the link to the event page on our website. The PowerPoint presentation is posted on our website, and you should have received it in the day's details email. And within the next few business days, a recording and a transcript will also be added. Be on the lookout for emails about our next webinar. Thank you again for attending, and hope you have a great day. Thank you, everyone.
The reader has disconnected. The conference will be terminated in 5.